Hello and welcome to Choosing the Right Preventative Products for Patient Outcomes. My name is Jamie Collins. You see my email there at the bottom, as well as my website. I want to thank Henry Schein for sponsoring our webinar this evening. Wonderful to have supporters of education and as we move forward on it. So my background, again, you see my email there at the top. If you have any questions, please do not hesitate to reach out. Likewise, if you have questions as we go along, please put them in the Q&A box and we will answer them at the end. So my background is 23 years in the dental field. I've been both an assistant and then went back to school and went to school for dental hygiene and have done that ever since. I am very fortunate that I get to travel and speak to groups as yourself, whether it's live or webinars, which we have the very great opportunity to do. I do work as a KOL and subject matter expert for various companies. I've also worked heavily in education and curriculum and course development for multi-state school systems. I've been very fortunate that I've been able to author multiple articles and had over 70 published to date, and been a contributing author to multiple textbooks with Elsevier Publications. I also do a lot with dental billing and coding as part of the Dental Coding Consortium, where we provide code creation testimony to the ADA and the CMC every year. And I'm the professional education manager with Mouthwatch. So we're going to touch on a few topics tonight. We're going to identify the preventative care products that really can help improve patient outcomes. We're going to look at not only professional products, but we're also going to look at home care products. And we're going to review some of the options that we have based upon patient oral care indications and oral systemic links that we do see as well. And then we're going to talk about the importance of selecting the right disposable products we use clinically that may impact us as dental providers, as well as the ease of use and the patient outcomes. Why do patients come see us? They come see us for a variety of reasons. They may come in complaining of loose teeth. They might complain of bleeding gums, halitosis. Pain is a very motivating factor. Maybe they notice their gingiva is red and swollen, might be tender, might have sensitivity to hot, cold, brushing, different things that they do. And they may also have noticeable recession. We see these patients that are coming to us many times for these indications, but we also have our patients that come to us for preventative care, so they don't find themselves there. And it's what we do as a dental and oral health care provider and what we recommend for them at home that really makes a difference. We know one big key to patient outcomes is the removal of calculus. It helps to reduce inflammation, and it improves the tissue response, and it also promotes healing of the gingival tissue. We know biofilm production is equally as important, and it helps maintain that balance that can be so delicate in the oral microbiome. Things we do at home, our diet, can often affect the biofilm formation and that microbiome as well. We look at things as well as the benefits of power scaling. Again, we're talking about how we improve patient outcomes. We know there's a lot of benefits with it. One is that mechanical removal of calculus and biofilm. That water helps to flush everything out, and it helps to conserve the cementum of the tooth versus repeated hand scaling. We also know it's bactericidal. We're helping reduce that bacteria count when we implement our power scalers. We also know that it has improved access over hand instrumentation, and it affects especially the gram-negative bacteria in the oral cavity. We know the benefits are also very dependent on the operator use and how we adapt those tips and how we utilize them as well. But we also have to consider when we talk about outcomes, especially provider outcomes, we know it's beneficial for both the health of the patient, but it's also beneficial for the health of us as a dental provider. We're talking about repetitive injuries and ergonomics. So very important to remember those aspects. When we talk about our professional aspects too, we can't underestimate the power of our hand instruments that we have. We know that we want ones that have a larger handle in diameter, that are less than 15 grams in weight, helps to reduce the hand fatigue and the pinch force that we have. So it's reducing the tension on the body. Therefore, we're protecting our bodies to help us practice longer, to help us practice more efficiently, but to also keep us out of pain as best we can. We also want to maintain that neutral hand, wrist, and arm position when we're working with these preventative products with our patients as well. And the prevention that we do, because it is such a repetitive source. We want to avoid flexing and extension to extremes when we're moving the hand, the fingers, the arm, the wrist, the elbow. We also want to consider a palm up fulcrum that's going to help reduce the tension on the hand, the fingers, the palm, the wrist, and stretch when you can. This is very, very important that many of us don't take the time or find the time to do. So be aware of your body. It's going to help you practice better, and it's going to help you practice longer and without pain. And coming back to why patients come to see us, oftentimes they come to see us because of a concern. We know society has become much more health aware and oral health aware in the last few years. People are becoming more cognizant and are more aware of their own bad breath or their own malodor as well. With that oral health, and you put a mask on it, they're going to smell that periodontal disease. They're going to smell that decay, the caries that they have as well. And that many times is bringing the patient into your practice, asking how to treat it and how to prevent it for future use as well. But what are some of the common causes? We often see excessive amounts of oral bacteria. Untreated periodontal disease is very common when it comes to malodor, as is caries. But do you think as often about xerostomia and how that impacts the odor that's coming from the oral cavity? Because for many patients, they don't realize they have xerostomia unless it's very, very severe. So we're seeing those oral implications sooner. Odor is also caused by infections, and tonsil stones are very common. As part of your intraoral and extraoral exam, you should be looking at the tonsils, and you should be able to identify tonsil stones when present. We also have gastrointestinal reflux disease, or GERD, that is very common, and it doesn't always have to be the fluids that are coming up fully into the oral cavity, those gastric fluids. Sometimes it's simply the fumes or the odors from the stomach content or the gastric content that's causing the malodor. Undiagnosed GERD is very common, and many don't realize it because it comes on gradually or they experience it when they're sleeping at night. But we also know other medical conditions can contribute as well. Many patients are dealing with either diagnosed or undiagnosed conditions that will be a contributing factor to the malodor, which may be the reason they're coming into your practice. When we look at the excessive oral bacteria, we know the tongue harbors 50% of all the oral bacteria. We talk so much, and patients, many of them I have experienced, think about brushing their teeth. But many of them don't consider they also have to clean the tongue. So there's toothbrushes, there's tongue scrapers, there's things we can recommend at home as a preventative measure. We know there's estimated about 20 million bacteria in the mouth at any given time. Some have more, some have less. And we know of those, there's about 1,000 different types that can be found in the oral cavity. Gram-positive are mostly found in dental plaque, where gram-negative are generally the odor-causing bacteria. These are the ones that are going to live in the pit and the fissures of the tongue. So brushing the tongue or using an adequate rinse that will help neutralize that bacteria is going to be key when we recommend. I want to be these older ladies. We're also seeing much more of our society that is growing older. And as the older population is the fastest growing segment of society, we also have to consider they're keeping their teeth longer. We know currently the accepted range to be identified as an older adult is about 65 years of age. These patients are coming in to see us who maybe have a complex medical history, as well as a complex dental history. Many restorations that have been patched or repaired over time. And now we're looking at preventative measures to help them keep their teeth and keep that dentition healthy for as long as they possibly can. So let's look at some problems we often see relating to aging too. And what are the common problems we're going to see when it comes to preventative measures and preventative products we're going to have to recommend, because nobody is really created equal. What one person may have is a concern or problematic, another may not. So we have to be able to really customize what we're recommending. Again, we know the population is growing older and they're retaining their teeth longer. They have more extensive and many times older restorations in them. We've all seen some hero dentistry where there's no reason that this tooth should still be hanging on with an MODBL, almost entirely restoration versus a crown. So we're seeing those restorations longer. And we're seeing that construction again is more challenging. But we're also seeing more dental exposure on those retained teeth. And it's harder for that to remineralize. And with that exposure, they're oftentimes coming in too and complaining about sensitivity, or they have recurrent root caries that we have to consider. We also know prescription medications are the leading cause of xerostomia, which is going to raise the risk of oral disease. When we see this with our patients, we have to be able to identify not only the xerostomia, but the risk factors that maybe will alter the way we're conducting our preventative procedures and may alter the way and what we're recommending for at-home use as well. With that, we have to consider many times the ability to maintain good oral hygiene. Are they dealing with healthcare issues like severe arthritis? Because we can't ask them, in that case, to wrap floss around their fingers and to floss interproximal if they're struggling with simple things like holding a toothbrush. But what many patients don't realize when we talked about xerostomia, they don't realize it impacts them because it happens so gradually. And in fact, 10 to 26% of men and 10 to 33% of women have xerostomia. So this is something we need to look at and really consider as we're kind of that preventative specialist, but we're also a little bit of a detective. We want to consider, do they have xerostomia? What risk does that have? And why does that change what we recommend for treatment, both professionally and what we recommend for them to do at home? Another very common cause is dental caries. 92% of adults have or have had decay at some point in their life. When we look at untreated decay, 20 to 34-year-olds are about 28% of untreated decay. 35 to 49-year-olds are about 25%. And 50 to 64-year-olds are about 22%. Again, we want to treat the disease, but we also want to focus on prevention as we move forward as well. And smoking and oral care. We know smokers have 2 times the risk of periodontal disease. The longer you smoke, the greater the risk of developing it. And periodontal treatment is not as effective for smokers as it is for non-smokers. What they're also finding is people that use e-cigarettes or vaping devices very commonly match what we're seeing in smokers as far as oral conditions and many times systemic conditions as well. Oral squamous cell carcinoma is the most common type of cancer and accounts for 90% of all oral cancers. In the US, 54,000 Americans each year are diagnosed with a 57% survival rate at 5 years. Worldwide, it is the number 8 ranking most common type of cancer we see. And the World Health Organization says it's 6.4 million people worldwide. And the trend that we're on suggests 8 million people by 2030. We know cigarettes contain about 70 carcinogens. And the Epstein-Barr virus and the human papilloma virus, especially the 16 strains, are common contributors to oral cancer, especially in younger ages that we're seeing. So prevention goes beyond just your instruments or your prophy cup. It also includes counseling when we talk about it and educating our patients as well. One of the most common diseases we see that has a very strong impact on oral health is diabetes. There's 346 million people worldwide who are diabetic. Over 80% of those with diabetes live in low and middle income countries. And about 34.2 million in the US alone are diabetic, with 8.1 million undiagnosed. 88 million are considered pre-diabetic. And by 2030, the World Health Organization says diabetes deaths will double between 2005 and 2030. 1 in 3 Americans will be diabetic in their lifetime. And we know 90% of diabetics have oral manifestations of the disease. We're preventative specialists, but again, we're also somewhat of a detective because we're identifying things that don't look normal or have an abnormal appearance to them and making those referrals and recommendations as we see fit. One of the most common things that we see with diabetics, especially uncontrolled diabetics, is chronic and acute as well, periodontal disease. Periodontal disease that does not respond to treatment. Poor wound healing. You don't want to do a dental implant on a patient who is an uncontrolled diabetic because the risk of failure and infection is much higher. So we want to identify these as part of our prevention and as part of our specialty in there as well. Another very common thing we see is what causes sensitivity. They come in because something hurts or something is uncomfortable. And it can be caused by many things. It can be caused by cold. It can be caused by heat. They may notice it with sweets. Sometimes if they're brushing, it may be really sensitive, or using an alcohol-based mouth rinse. I often hear from people that will be outside during cold weather and say, I can't breathe in with my mouth open because it hurts. So we're identifying these concerns and we're providing them with professional treatment, again, and home care solutions, which we'll get into some options here in just a moment. But don't underestimate the power of your intraoral camera and your intraoral images. It is one of the biggest factors we see in behavior change. When I can show a patient what I see, the buildup, the decay, the recession, as part of my oral hygiene instructions, as part of my home care instructions, that is one of the biggest motivating factors that I do have. They're very affordable now. Again, if you don't have one, I would look into getting one because it helps to help the patient understand. It also takes the selling out of dentistry when we can explain to them why something is the way that it is and what we can do to change it. You also have to consider not your typical teeth. We need to have special considerations for prevention with special cases. So whether that is dentures or partials, it might be implants or implant-supported dentures. There are better options for home care and professional care to treat those than the traditional brush and floss only. For these, I'm a big fan of interdental brushes because those brushes are going to gently work their way around the threads, but you have to be aware of the type of brushes that you do use. But they're going to work their way around those threads and really help to clean those out a little better than traditional floss would. And polypharmacy. So polypharmacy is classified on being multiple medications. Generally, we see over 4, maybe 5 medications. We've all had those patients that come in with a medication list that is 2 pages long, or they don't know what they're taking exactly, but we know it has oral implications. And we're also educating our patients on that because many don't think that their teeth or the dentition is affected by systemic conditions or medications. They think it's very separate. But we know polypharmacy has also noted that it can have aphthous-like ulcers in the individual. It may alter their taste. Many times they're more prone to a fungal infection. Depending on the medication, they may be more prone to hyperplasia or lichen planus. But we do know there's over 500 to 900, depending on which study you read, medications that list xerostomia is one of the most common side effects. We should be updating that medical history every patient that you see, every time you see, because often they don't think about it. So we know some of the reasons they come to see us, and we understand why, but let's understand what we can do for them. How can we have our professional side and our home care recommendations align for the best possible outcome for the patient? And again, in turn, it makes our job just a little bit easier. One thing to definitely remember is home care is not a one-size-fits-all concept. So what might work for the gentleman that you see on the left is probably not the same recommendation you would have for the child on the right. And how do those vary? Because every patient is an individual. And what may work for me may not work for you. And we have to consider multiple things. What are we looking at for dental problems? Are we looking at gingivitis or periodontitis? Is their biggest issue hypersensitivity? Might it be caries? Might it be that calculus buildup? And many times it's not just one. They're going to cross and maybe merge together for a bigger problem. When we're talking about how we treat patients and our preventative measures, ask yourself, when is a handpiece more than just a handpiece? Because many practices have the old clunky handpiece that's really heavy, that doesn't swivel, that doesn't fit as it should. And what that equates to is more strain on the dental provider and what it can contribute to as well. So some factors to consider: the weight of your handpiece, the design of it, the torque. Does it accept any propy angle? I will be the first to admit I have my favorites, as I'm sure many of you do as well, and what we like to use. Does the nose cone rotate or is it stationary? We also have to consider the patient comfort, because that's a big part of it. If it's loud and chattery on it, It may be very uncomfortable for the patient, especially one who's nervous coming in. And again, we look at the cost. Handpieces should be sterilized between each and every patient. You may want to consider, again, handpieces in that way. In some cases, you may consider a cordless handpiece. It's whatever's going to suit you as a provider, the fit in your hand, and the fatigue on your fingers, your wrists, your palm. Because dental studies say that 93% of dental workers have reported pain. Depending on the study, it's 20 to 85% neck pain, 18 to 73% shoulder pain. And over time, it's a chronic injury. That's going to manifest through decreased muscle function, numbness, strains. It may lead to a partial rupture of tendons and muscle or tendinitis. So again, ask yourself, when is a handpiece more than a handpiece? It's worth the investment to help ensure that you are able to practice a long and relatively healthy career path. Preventative measures, we want to choose the right disposable prophy angle. I highly recommend disposable rather than the little cups that you screw on individually. It's a lot easier. It's a lot cleaner. Overall, I think it works much better. And ergonomics matter, absolutely matter, as I mentioned. So there's options. There's a contra angle handpiece that has a bend to it, or there's a straight. So it's what works best for you as a provider. Me personally, I always use the contra angle because I don't have to flex my wrist or my hand as much to adapt that to the posterior. I prefer that angle over some others, but again, it's a very individual choice as well. And there's different cups. There's a soft cup, there's a medium cup, there's a firm cup. When we provide pressure on that cup, if you think back to your dental education days, that cup should have a slight flare in it. So you want to use one that's going to flare just slightly with as little pressure as possible. Because if you're relying on the finger grip only when using a disposable prophy angle, it puts unwarranted stress on the fingers and the palm, can lead to damage and can lead to fatigue, ultimately may lead to carpal tunnel. Increased access. Prophy angles 20 years ago used to be very bulky. It was hard to see around them. Now they're slimmer, a little more sleek. They're able to make them smaller. So it's an easier adaptation to get back to that posterior tooth. Consider the chatter and the splatter as well. So the gear design will lead to, if it's not quality made, that gear is going to slip and that prophy angle is going to be very noisy. It's going to chatter a lot, which can be uncomfortable for the patient. But with that chatter also creates extra vibration, which is harder on your hand as an operator. And think about the cup design. Do you like the cup that is webbed on the outer edges of the cup? Or do you like a smooth one? Personally, I liked the webbed cup on the outer edges because I can kind of tuck that and adapt that to areas that are a little bit harder to reach. And then, of course, cost. We have to stay within a certain realm, and cost has to be very affordable and agreed upon by the practice as well. So selecting the right prophy paste when we talk about disposables is also another key element, because prophy paste uses mild abrasives, and that's what's going to help remove some of that plaque, as well as those extrinsic stains. Many times we find patients that care less that we're working on periodontal health. They just want you to remove the coffee stain. So this is part of our job that we have as well. And they come in fluoride or fluoride-free options. Many have a calcium phosphate. Many of them have xylitol in them. We know xylitol is a good antibacterial as well to help reduce the bacterial load. And they come in fine coarse, medium, as well as extra coarse. Extra coarse should be used with a lot of caution because it is so abrasive. And maybe we use it on those that are only very, very, very heavy stain and use it very selectively. Usually a fine to a medium is indicated in most cases. And when we select stuff for patients as well, we need to think about that mechanical removal of the biofilm and consider aspects, manual dexterity. This is key for many, especially as we know our patient population is aging. So we have to identify, are they able to hold that toothbrush? And consider the toothbrush design. We want it to be a soft grip and always, always a soft or extra soft brush. We know many of our older patients have always warranted or tried to find that medium or hard brush that used to be recommended back when they were children or young adults. And now we know better. But you also have to consider that many of them have never really had the technique for proper toothbrushing or to understand how to do it correctly. And there's ways to do this and ways to review it without coming across as condescending as well. I always do these same instructions with each and every one of my patients, and that includes a frequency of brushing. I'm a big fan of power toothbrushes if we can get patients to use them, especially those that have dexterity problems, because for most people, it just does a better job. And denture care. They should be aware that even if they do have dentures, they still need to come in for preventative appointments and screenings. We need to remove that denture and screen for oral cancer or any abnormalities. When they remove their denture, they need to store it in water or a denture cleaning solution. It's going to help it retain the shape. They may need to reline it periodically or use adhesive as indicated. And also recommend that they use a non-abrasive paste and a denture brush to clean it multiple times a day, just as if they have natural teeth. I find that many patients are also reluctant to remove their denture because they're self-conscious. We need to remind them the importance of it for the health of the tissue and the cleanliness, that they need to do this and let that tissue breathe a little bit. And again, the importance that we need to inspect them each and every visit, even when a patient comes in with a denture, say on the upper arch, and we're cleaning natural teeth on the lower arch, you should always remove that denture and screen underneath. But many patients come to see us for whitening. This is a goal. This is what our society says, is we want nice white teeth and white smile. So we want to choose a product that is going to be low for sensitivity. There's the trays and the gels, but now there's also whitening strips that they can apply to. These ones here, they dissolve away. So they place the strip on, it does its job, it dissolves away. So it's very easy to use with very little hassle with it too, and very little sensitivity. I've had my family members try out this particular one with great success and very happy with it. But it's not always whitening that causes sensitivity. Many times that will be recession again, or something along that line. And so we want to recommend, again, not everybody's the same. The desensitizing gel and instructions for use. So when we have it, you should follow the manufacturer's directions, but they can apply it in a variety of ways. Whether this is post-whitening or this is just to maintain reduction of sensitivity, to maintain daily living, things they enjoy, having that hot coffee or having that ice cream. They do their preventative home care as normal, and then follow up with the desensitizing gel, which will help occlude the tubules that are carrying that sensation. And the goal is to lead to reduced hypersensitivity And therefore, their patients are going to be happier. And when they come see you, it's also going to be easier for your preventative care appointments because it's not going to be as sensitive when we try to clean things in the office. One thing we do need to consider is modifying behaviors. Many of our patients have higher rates of decay, staining, sensitivity due to the fact with what they're doing at home. Part of this is acid exposure. So they're drinking acidic beverages throughout the day or very common consumption of them. We recommend that they drink water in between. When we talk about food choices, we want a mixture of acidic and non-acidic foods. So if they have acidic beverages between meals, something like a xylitol gum or a mint will help buffer that with the saliva and help promote the buffering capacity. Cold beverages are generally considered better than hot when we talk about sensitivity and the effects on the oral tissue in the teeth. And then sometimes maybe using those acidic beverages and using a straw with it will help as well. And I remind them not to swish it around. So I like a glass of wine just as much as anybody else, but it's how we do it that makes the difference. We also know soft drink consumption has increased 500% in the last 50 years. On average, in the US, each American is drinking about 56 gallons a year. And about 80% of 14-year-olds drink a greater than 20 ounces of soft drinks daily. This is a problem. This is what leads to not only things like obesity and poor health outcomes, but it also helps lead to dental decay and dental disease. The average size in the 1950s of a soda was 6.5 ounces. In the 60s, it became 12 ounces. By the late 1990s, it was 20 ounces. Now, you see people walk around with a 32-ounce drink that's sugar and acid, and they sip on it throughout the day. This comes back to our education part with our patients, but it also leads us to practices that we can do professionally that may help counteract some of the damage it's caused. Fluoride is a big thing we have at our disposal. Of 5% sodium fluoride is the active ingredient in fluoride varnish, and it can help with hypersensitivity. Post-periodontal surgery, it can help reduce that sensitivity there as well. For somebody that is a medium to high caries risk or post-scale and root planing or has root exposure, it's really beneficial and it'll make it feel much, much better for our patients. The fluoride varnishes come in a simple one-dose unit package, very easy to apply. Many times it's transparent on the teeth, and it has that xylitol in it that will help combat the karyogenic bacteria. So fluoride varnish is dual purpose or multi-purpose, I should say. I often will use it post-scale and root planing to help reduce sensitivity with my patient right afterwards. Because now we've removed that calculus layer and exposed the tooth structure or the dentin, which is going to be more sensitive. So we want to make it as easy as we can on our patient with the least amount of side effects. Patients that are at higher risk for caries or root caries, especially some of our elderly people with xerostomia, I'll often recommend a home fluoride. So this can be the 1.1% sodium fluoride gel, maybe a stannous fluoride as well. These are prescription strength. However, you can order them and carry them within your practice to have them on hand for the patients it's indicated with, which is something I like to do rather than to hand them a prescription. And they don't take up much room. They're more apt to use it if they can leave your practice with it in hand. And tell them why. Tell them the benefits of it as well, especially if they have sensitivity. or if they're at a higher risk. There's many ways they can do it. It can be within a paste form, or it can be in that gel form where they brush on, or they can utilize that gel in a carrier tray, much like our whitening trays as well. But what do we do if they don't floss? Because the standard for so many years has been brush and floss, brush and floss. But we know many patients don't floss, or they don't have the dexterity. But we're blessed with many options that we have. One of them, we can use the floss picks. They're simple, easy, one-handed use to get in between. For many individuals, this is the only way and the only thing they get in between their teeth with, and I'm perfectly happy with it because for a lot, it is the most effective option. Maybe using an oral irrigator may be indicated because they have the ability to utilize that in a variety of ways, especially if they have periodontal disease or higher risk factors for it. That oral irrigator is going to help flush everything out for us. And we know, again, over 50% of all bacteria in the oral cavity live on the tongue. So if they're brushing their tongue, it may also be indicated to use a tongue scraper to be very, very beneficial in that odor reduction. And there's other options, as I said. I'm a big fan of power brushes. For xerostomia, there's a variety of things on the market that we can utilize to help reduce the xerostomia effect. And we bring that to their attention because they may not realize that they're dealing with it until we help point out the symptoms that we see. Interdental brushes, I think for many patients, are probably more effective than string floss because the interdental spaces or the restorations may be wider or have a little bit of a ledge onto them. And the brushes or the picks are going to adapt to those much better than the floss would. Rinses, it may be indicated for a chlorhexidine rinse or an alcohol-free rinse, or even the chlorine dioxide rinses are very effective in reducing the odor and killing off the bacteria, or reducing the bacteria load, I should say. So they provide that added benefit to it. And is chlorhexidine indicated? It is a prescription. We know it's a strong antibacterial, but it's indicated only for short-term use. It is not indicated for long-term use. We often see it after oral surgery or non-surgical periodontal therapy, extractions, because it helps reduce the bacterial load in the oral cavity. You do need to instruct your patient that it may cause a temporary brown stain to it, especially if their home care is not ideal. So they may come back with a little bit of staining, but that polishes right off with your Prophy Cup and Prophy Paste. The taste for some can be a little bit off-putting, a little bit medicine-y, but it is very effective and it definitely has a place in dentistry. You also want to ensure that you're using quality instruments because it's going to help for patient outcomes, but it's also going to protect yourself and the ergonomic aspect as well. You're protecting your hands, you're protecting your career, and you're protecting your investment. So make sure your instruments are sharp as they need to be. They're not broken. Use ones with a little bit bigger handle. It's definitely worth the investment. I notice a strong difference when I use a small handle scaler versus a little bit larger diameter in hand fatigue. Let the patient's needs, their motivation, and their desires dictate your recommendations for treatment. For this patient here, really their desire may be get out of pain. When we look at this as dental professionals, not only do we want to see full restorations and replacing missing teeth or broken teeth that are beyond repair, that may not be their desire. We're looking at preventing future damage and hopefully correcting the damage that's done to the best of our abilities. So we talk to them because it really is a group conversation. It's more than just saying, here's what you do, go home, brush, floss, use this rinse. It's a conversation to have with your patient. You need to know their motivation. Do they even have the desire to keep those remaining teeth? And let them know in a very educational way both the pros and cons of it all. But most importantly, do not hesitate to refer patients that you suspect that may have a systemic or underlying condition that is contributing to the problems with the dentition. Many things often show up in the oral cavity before there's other outward symptoms that are recognized. Diabetes, for one. We may see the first signs of it when we see sudden or drastic changes in the periodontal health. We have the ability, we can screen for a hemoglobin A1C in the office, or we can refer, just as you would refer if you found a nodule on the thyroid. It is no different. You're not being asked to make the diagnosis, you're being asked to identify concerns and have them addressed accordingly. I have done this with many patients on different circumstances, and many patients, it's been very successful, and they've come back and they said, I had no idea, but thank you. So don't hesitate to refer, because what we see as an oral health condition or that we're combating with preventative products and moving forward may have an underlying reason for it. And most importantly, create a plan together. This goes with the motivation from the patient, their desires. This also goes with their abilities. Do they have the dexterity to utilize these home care instruments that you're recommending? No patient, or few patients, I should say, are willing to do a 6-step regimen. So we want to make it attainable. And that comes with talking with your patient, understanding the desires, and how we can move together for a better outcome for them in the future as well. I want to thank you for joining me. My email is there at the bottom. Please don't hesitate to reach out. And let's go to the questions. So is chlorhexidine not recommended after scale and root planing since it may inhibit fibroblast attachment? I have seen both ways, that some studies say use it sparingly after for a period of 3 days to 2 weeks. And I have seen some studies that say it may inhibit it. I think that's a case-by-case basis to weigh the benefit versus the risk. Any other questions? Please don't hesitate to put them in there. With chlorhexidine, some patients, the stain polishes right off, some it does not. Is there something that makes that the case? I would say probably due to a little bit rougher enamel, or if they have modeling of the enamel, that's probably the contributing factor. I've had fairly good luck with it coming off in most cases. Sometimes there's been areas on the root surfaces that are a little bit more porous that it doesn't come off as easily. Oh, and I don't see any more questions. Again, thank you for spending your time with me. Do essential oils have any benefits? I have read both ways. I think it can be, especially when the essential oils are utilized as part of a product versus just the essential oil straight up, which I've had some patients try to do, that can have a little bit of a burning aspect to it. Again, I think it depends on the oil. Stephanie said, we have the ability to do the hemoglobin A1C testing in office. I haven't heard of this. You absolutely do. We actually have CDT codes for that now, that it is available to us. I would look at your State Practice Act, depending on the state you're in, which will determine if that could be administered by the dentist or it can be administered by the hygienist. But it is in your CDT manual. It has been for about 2 years, and we have the ability to test that now. And it is just a poke. It is a finger stick as well. It's not a blood draw. You can buy those kits off of things like Amazon, where it's about $50 for 2 or 3 kits, that you can utilize them there, especially for patients that you suspected. I've had many that don't see a physician on a regular basis, but will come see me on a regular basis. So we're kind of that front line. There are some alternatives to chlorhexidine. There's various products out there that are a great alternative as well. I would look into those. And again, it's a case-by-case basis to determine what the best choice is for that individual patient. I don't know that they're quite as effective, but many of them are very close. Wonderful. So thank you, everyone. I appreciate you staying with me and spending the last hour with me. And I will turn it back over to you.